Good morning and welcome. I'm Jennifer Butcher from the University of Michigan. On behalf of myself and my co-moderator, Shayna Blair from Children's Hospital of Atlanta, who will be working hard behind the scenes to organize your questions, we'd like to welcome you to our workshop, Novel Virtual Psychosocial Interventions. We hope to provide you this morning with examples of promising intervention strategies focused on patient and family support, medical regimen adherence, psychosocial and behavioral skill development, and targeted psychoeducation delivery remotely across the lifespan. Please type any questions that you have in the Q&A box throughout the session, and you can also upvote a question by clicking the like box. Our first speaker will be Dr. Courtney Lynn from Children's Hospital, Colorado, who will be speaking to you about a psychosocial intervention for supporting parents of younger children.
Hi, my name is Courtney Lynn, and today I'm going to be talking about CF Pact, a telehealth parent management group for parents of toddlers with cystic fibrosis. Today I'm presenting on behalf of myself and Andrea Villalobos, one of our psychology students, who really helped to make this project possible. I have no relationships to disclose related to this presentation. So for our agenda today, I'm going to talk a little bit about how CF Pact came to be. I'm going to give an overview of the content that we covered in each session, and then discuss some outcomes that we found as well as conclusions. So how CF Pact came to be. I think a lot of you are going to be able to relate to what I'm going to put up on the screen, but during the height of the COVID-19 pandemic, we saw a lot of kids staying home from school. And so as a result, during clinic visits, a lot of parents were expressing increased concerns with behavior difficulties, a lot of difficulties with online school, being able to get their kids to sit still and focus, as well as a lot of difficulty really creating a new routine and keeping that routine when there was so much that was in flux and so many changes constantly going on. So as a result, we decided to create a telehealth parent management group intervention. We chose to make a group intervention to really target a wide variety of parents and make it a little bit more efficient. And then we targeted telehealth because we do serve families across the state of Colorado and other regions. So telehealth really limited some of those barriers to care. And also during COVID-19, we wanted to make sure that we were taking as many safety precautions as we could, and telehealth really felt like the safest option. So I want to talk about our service delivery model and discuss how the parenting group falls within that model. So a lot of you are familiar with several of the universal screeners that we have. So the CF Foundation recommends universal screening for adolescents for depression and anxiety, as well as caregivers of individuals with CF for depression and anxiety as well. In our clinic at Children's Hospital, Colorado, we also implement a universal postpartum depression screening for caregivers of babies with CF within their first year of life. We have a universal school-age behavioral health screening, and then we also do some screenings or some assessments for CF Rise, and then a responsibilities checklist for transition. So we have the targeted intervention group, which really focuses on those health and behavior assessments and interventions that we provide during CF clinic. And then we have a variety of health promotion and prevention groups, which is where the parenting group falls. So it's important to identify that the parenting group really falls within this targeted category, because we weren't specifically looking for parents that were experiencing really significant behavior concerns with their kids. We really wanted to offer this group to a variety of parents who were maybe just having minor difficulties, to parents that were having more significant difficulties, and then they ultimately maybe ended up needing some intensive treatment afterwards, which I'll talk a little bit about how that worked. When the parenting group fell within this targeted category, it also helped us develop the scope for the group and what we should address, as well as the outcome measures that we wanted to target. So recruitment for the group occurred in a variety of different ways. One of those was during CF clinic visits. So if we went in the room, parents were kind of expressing concerns. We provided the group as an option for them. Like I mentioned, we also do a universal school age screening using the pediatric symptom checklist. And at the bottom, we have a presentation that goes into more detail on this universal screening. And then a lot of providers saw patients who they thought would be good fits for the group. And so we had a referral system from some of the providers as well. So in terms of outcomes, like I mentioned earlier, this was a targeted intervention. So we were not expecting to see a really big change in behavior concerns. There might be some change, but really what we were trying to target was parenting competency. We really wanted parents to feel like they had more control over behavior, especially during the pandemic, and really increase their repertoire of some of the parenting skills that they had. So we gave the parenting sense of self-competency scale before the intervention. Parents engaged in the CF PACT intervention, and then we gave that scale post-intervention along with some qualitative feedback that looked at acceptability and feasibility. So now for the session content. So we had CF PACT overall consisted of 4 telehealth sessions and 1 telehealth coaching session. Each session lasted around 60 minutes. Some sessions were a little bit less or a little bit more, depending on how much parents had to talk about. The group was facilitated by a psychologist and psychology trainee. And we took and adapted content from a variety of different evidence-based interventions, including PCIT, parent management training. We took some modules from Match ADTC, and as well as the book, The Whole Brain Child. So session overview. Each session looked pretty similar in terms of the structure. So we talked about what stuck from the previous week, things that they worked on, any difficulties, some successes. We introduced new content and then set goals for what they were going to practice in the upcoming week. So session 1 focused on strengthening the relationship. We, in the beginning, in order for parents to get to know each other, we had them identify values that were important to them, as well as some barriers and facilitators for being able to parent in a way that was most in line with their values. We introduced the parent-child coercive cycle and had parents create examples from their own lives, and also gave a brief overview of how to break the cycle and talked about some ways that we were going to address that in future sessions. We also introduced one-on-one time as really the foundation for behavior change. So in a lot of parent management programs, one-on-one time really is essential. And so we discussed how one-on-one time was going to serve as the foundation and reviewed the pride skills that are used in PCIT for parents to start practicing. The second session focused on reinforcing the positive. So for the 2 to 3-year-old group, we introduced the ABCs of behavior. So we had them come up with examples from their own lives of how the ABCs of behavior played out, and had them kind of come up with examples in this regard. We also introduced active ignoring as something that is used to break the parent-child coercive cycle. Sorry, my slides are not advancing as quickly as I want, but that's okay. And we talked about more ways to increase labeled praise. So we had parents practice generating labeled praise for opposite behaviors. So you can see on the left, we gave some behaviors that we would want them to maybe ignore, the opposite behavior that they would want to see. And then we gave a lot of stems for creating labeled praises. And then for the 5 to 6-year-old group, we talked about reflective listening. So we gave them sample vignettes of a child who didn't want to do CF treatments anymore. Some kids were joking them in class for coughing so much. And we gave a non-example, so a parent who was not practicing reflective listening, an example of a parent who was practicing reflective listening. And we talked about how those differences felt. For giving effective commands, we discussed the do's and don'ts for giving effective commands and had parents practice ways of improving commands. So we gave them a list of some commands, asked them to identify what went wrong, and had them generate a better command. During session 4, we introduced a variety of different tools. So we talked about time out, what it was, and gave them a sample practice sequence. We discussed a calming toolbox. So we talked about ways that parents can find strategies and items that really help their child to relax and calm down. We discussed sticker charts. A lot of parents had already tried to use sticker charts, so we tried to discuss barriers to sticker charts in the past and how they could use them moving forward. And then at the request of the 2 to 3-year-old group, we discussed the bedtime pass because a lot of families were having trouble getting their kids to sleep in their own bed. We also, with the 2 to 3-year-old group, implemented one-on-one individual coaching sessions where we observed specific difficulties that they were reporting. So for instance, meal times and treatment. And it was really these one-on-one coaching sessions that helped us to modify the next level of treatment and what they might need. So I'm going to discuss our outcomes. So for cohort 1, there were 3 families, and after the intervention, 1 family was referred for ongoing parent management training with the CF psychologist. So 2 of the families felt like the strategies that they learned were sufficient to kind of address the concerns that they were having, and 1 family really needed a little bit more intervention, and we were able to provide that. The second cohort consisted of 3 families, and 2 families were referred specifically for ongoing feeding therapy with the CF psychologist. And so they were able to address a lot of concerns, maybe related to vest time or listening and following directions at other times of the day. But feeding still was a major concern for families. And so we referred them for more feeding therapy. Like I mentioned, we were really targeting parenting self-competency. So we did not run any t-tests because the sample size is really small. We had 5 parents complete both pre and post-test. But we did look at effect size and found a large effect size of 1.09. In terms of feasibility and acceptability, we asked parents a variety of questions about the group setting, online format, whether or not they would recommend the group. And nearly all parents agreed with these statements. 1 parent slightly disagreed that she enjoyed attending each of the sessions. The anchors on this scale was from disagree, slightly disagree, neutral, slightly agree, and agree. So most of the parents agreed. In terms of feedback, we asked them what else they would like us to know about each session, things they liked or didn't like, what they wanted us to add or take out. And so parents provided qualitative feedback. They recognized the importance of one-on-one time. They loved how to break the cycle. They saw they didn't praise enough, enjoyed learning about commands, being able to do reflective listening. This parent also had some teenagers that she was using this strategy with. And then talking about maybe trying sticker charts again. We also asked them to rate each of the parts of the intervention that I outlined earlier, from not at all helpful to very helpful, and all parents rated the individual sections as either helpful or very helpful. In their own words, parents enjoyed hearing from other parents, recognizing that they have same behavior difficulties and liked hearing what other families were doing. They liked learning how to approach their child in a way that wasn't forceful or demanding. Liked learning how their behavior kind of feeds into their child behaviors and how to create more positive interactions. And then just talking to other parents who have toddlers with CF and seeing how they're handling all the issues related to the pandemic. So in conclusion, the parents really enjoyed learning parenting skills in the group context. Learning these skills may increase their sense of competence in parenting, and parents really found that the groups delivered via telehealth was acceptable and feasible. As you guys all know, we're able to follow parents even after the group during CF clinic visits. So we've been able to talk to all the parents, and it's been nice to hear that the skills continue to work, or maybe they need a little bit of a refresher on labeled praise or giving effective commands. And so we've been able to kind of obtain more follow-up and really continue to reinforce these strategies even beyond the group. All right, I'm looking forward to hearing everyone's questions during the Q&A.
Welcome to the first Q&A session for the novel Virtual Psychosocial Interventions Workshop. You just heard a wonderful talk by our first speaker, Dr. Courtney Lynn from Children's Hospital, Colorado. Thank you, Dr. Lynn, for presenting on such an important topic. It's so helpful to have tools for supporting parents of younger children. For our first question from our audience is, were there ways that you tailored the parent management program to CF-specific parenting challenges?
Thanks, Jennifer. That's a great question. So each session, I kind of outlined the overall structure of talking about things that went well from previous week or barriers that they had. And so a lot of the parents brought in specific examples that related to CF. So maybe they were really targeting using praise during vest treatment, or they created a sticker chart that they were using for taking pills. And so a lot of the parents kind of naturally brought in those CF specific concerns. And then we were able to discuss the overall content and how that kind of related to the parenting challenges that they were experiencing. Some parents also had concerns that were not related to CF. And so we were able to problem solve those as well. But I think being in a group of other parents who had kids with CF really created an environment where they wanted to talk more about the challenges that were specifically related to CF and hear feedback from other parents about how they handled some of those challenges as well.
Thank you. Another question we have is, what time did you offer the groups? And what was the participation retention across sessions?
That's a great question. So we ran these first two groups kind of at the height of COVID. So a lot of parents were working from home, which made it a little bit easier to schedule the groups. And so we did offer, both of these groups happened in the morning, probably from like 10 to noon or 9 to 11-ish timeframe, and parents were able to make those times. We have since found that it's been a little bit more difficult to find times that work across a variety of families. So we're in the process of thinking of additional ways, if we offer the group in the evening or if there are other times that families are available. But during the height of the pandemic, it was a little bit easier. Participation and retention across the sessions was great. So I think we had one parent miss one session the entire time. But other than that, and we met with her one-on-one to kind of update her on the content that we discussed in that group. But other than that, everyone attended every session.
That's great. It sounds like parents were really engaged once they got involved with it.
Yes. And it was a small enough group, 3 families each time, that I think they really got to know each other. And so they wanted to keep coming to talk with each other and get feedback.
Yeah, I'm sure that social support was well enjoyed.
Yes.
Another question we have is, how do you use other members of the team to reinforce and support the skills longer term?
That's a really good question as well. So one thing, we have team meetings every week. And so after we ran the group, we gave a presentation to our team on the content that we discussed in the group and some of the outcomes that we saw. So the team was aware of things that we were working on. And so we were able to, more during CF clinic visits, remind the team of some of the skills and then have them reinforce them during visits as well. Also having the team just aware of the group and aware of the things that we were working on. We started to get more referrals for people who might be interested in the group, which at one point we had to kind of explain how it worked. We had to wait till we get enough people because they wanted everyone to kind of be part of the group at one time. So I think the team was really supportive of, learning the different skills and us giving a presentation on what skills we were teaching so that they could start to use some of those with the patients that we were seeing.
Thank you. It sounds like you worked really hard to involve everyone. You're getting lots of praise on a wonderful topic, wonderful intervention. One question is about confidentiality and consent. How did you go through this with families? Did they sign a consent form? I think people are wondering about this, especially because of the virtual format and not actually seeing people in person.
Yeah, so through our virtual, we use video through Children's. And so there's an online consent when they log into MyChart to kind of log into their appointment that they sign for every visit. And we did have a discussion during the first session of confidentiality and what that meant for parents. And we kind of discussed group norms that we had as well. But there is a consent form that they sign, but it's through the Children's Hospital that they get each time.
Great, thank you. We have a question about sharing your slides with audience members, and we will respond to that question. I think you'll be able to view this afterwards, so can probably see the slides. Another question that we had was about the handouts. Did you create them yourselves, or were there things you found that were already available?
We created the handouts ourselves. We chose things from different interventions, like the pride scales we used from PCIT. Reflective listening was in the whole child brain, but we kind of created the worksheets ourselves so that they were consistent across sessions in the way that they looked.
Great, thank you. And I think our last question is, what are next steps for CF PACT? Do you have plans to continue with this intervention?
Yeah, we really enjoyed being able to provide that like tier 2 type intervention where some parents weren't even having really significant difficulties, but they just wanted to increase their repertoire of skills in parenting. So we really like the model of having a variety of parents with, different presenting concerns. So we're planning on still providing CF PACT. We actually have 2 families. We're looking for another one so we can get that group going again right now. We have found that there's several older kids, maybe like 7, 8, 9, that are having some behavior challenges that maybe need a little bit more significant intervention. So we are trying to come up with a way that we can create either like a specific parent management training group or a specific PCIT group that's a little bit more intensive that we can offer in that group format as well.
Thank you very much, Dr. Lynn. What a wonderful intervention. And we look forward to hearing more about it in the future. And now we're going to move to our next speaker, Dr. Hannah Fahn, who's going to talk to us about using a medication schedule mobile application as part of CF care.
Hello, my name is Hannah Fahn, and I'm a clinical associate professor and clinical pharmacist specialist at the University of Michigan, Mott Children's Pediatric CF Center. Thank you so much for the opportunity to contribute to this workshop. Today, I'll be discussing results from one of the pilot studies from the CF Foundation Success with Therapies Research Consortium, Feasibility and Acceptability of a Medication Schedule Mobile Application as part of CF Care, a pilot real-world mHealth study in CF clinics. The following relationships exist related to this presentation. Of note, the study was supported by a pilot grant from the CF Foundation's STRC, as well as funding to support the data and study management cores who were central to the successful completion of this project. Medication complexity has been previously defined as 5 medications in adults and at least 2 medications in children. However, medication complexity is not only the number of medication a person has as part of their daily care, but also factors such as the variety of dosage forms in the regimen, the scheduling, as well as special instructions such as cycling on and off months. In a recent study by the pharmacy team at the University of North Carolina, it was found that increased medication complexity was correlated with decreased lung function and increased need for antibiotics and hospitalization. So with the rise of available mHealth modalities, how can we best use this technology to help support families with regards to medication management, including scheduling and reminders, providing information about purpose, dose, timing, and administration of medications? Ultimately, we ask, do the current available mHealth apps meet the needs of the CF community? Our team sought to start answering that question by looking at a mobile application called MyMedSchedule Plus or MMS Plus. It's a commercially available mobile application with a clinician web interface called Med Action Plan Pro. It is HIPAA compliant, including encryption. It provides patient and caregivers a medication schedule that is sent to their mobile device by their care team, which includes medication purpose, dose, and frequency of medications, as well as the ability to set dosing reminders, log the doses that were taken, and view their past dosing logs. The MMS Plus is the patient interface that the patient user sees, and this is on their mobile device. It's available on iOS as well as Android devices and has various screens with information and functions. There's the Today screen that shows medication scheduled for today, the Inbox screen, which shows any updates that were sent from the provider as far as the care plan, and a progress screen showing doses taken versus doses scheduled. And then a medication list that shows their overall medication list with the ability, once tapped on the medication, to show information about the purpose and frequency and dosing of the medications, as well as ability to set settings as scheduling. And then there's a final screen that shows any contact information for their care team. When a patient or a caregiver receives a reminder for a dose, you'll see at the top a reminder is set for a certain time and medications. And once tapped, opens another screen that's larger that shows the medications that are due. The person then has the option to be able to mark which medications were taken, or if they were all taken, or if there were any postponements in medications or delays. as noted here. The Med Action Plan Pro is the clinician user interface, and this is the web portal that syncs with MMS Plus, and it pushes out the medication plan and schedule to the patient's mobile device. The clinician uses it to manage and sync medication lists and schedule, as well as have the ability to view any dosing logs from the patient. The objective of our study was to evaluate the feasibility and acceptability of the commercially available app, MyMedSchedule Plus, for medication management as part of pediatric and adult CF care centers. The following study sites were those from the STRC, and a big thank you to the study site PIs and their research staff for their help in completing the study. The University of Arizona and Banner Health, SUNY Buffalo, University of Alabama, Birmingham, Johns Hopkins, and Stanford. This was a pilot multi-center prospective randomized control study of people with CF ages 12 years and older, of which we will call patient participants, and caregivers, which were caregivers of patient participants ages 12 to 17 years. Patients were prescribed at least one of the following CF medications per our study protocol listed here, and were randomized to receive the intervention, meaning the MMS Plus app, versus usual care. You'll also note here that clinician participants were also listed, and we are currently reviewing the data and data analysis underway, so please stay tuned. As far as this abstract presentation, we'll be focusing on the data from the patient participants and caregiver participants. So as mentioned previously, patient participants were randomized 2-to-1 to the intervention, meaning the MMS Plus app, versus usual care, meaning no app, for approximately 12 weeks. Prior to this intervention, they went through a run-in period of approximately 4 weeks, the intervention again at 12 weeks, and then following intervention, were asked to complete an intervention feasibility and acceptability questionnaire. You'll see here devices such as the eTrack and the AdhereTech pill bottle, and this was part of the overall study protocol, of which data and information will be presented at a later session. The IFAQ, or the Intervention Feasibility Acceptability Questionnaire, is a 30-item survey of which assessed features used and perceptions of those features regarding the app's engagement, usefulness, functionality, ease of use, aesthetics, information, and satisfaction. We defined feasibility and acceptability as a median score of 4 out of 5 on the Likert scale. Of those enrolled and randomized to the app, which were 43 patient participants and 18 caregiver participants, 27 patient participants completed the IFAQ and semi-structured interview, and 11 caregiver participants completed as well. As you can see, the average age of patient participants was approximately 21 years of age, with the majority having lung function of 70% or greater, with various comorbidities as listed here. Of the caregiver participants, most participants were college educated and had the following insurance status. Participants reported using the following features of the app, including over half using ability to add or change medications, using the progress screen to track doses that were taken, as well as using dosing reminders. Participants also reported use, on a lesser extent, the use of features such as updating the schedule themselves, changing medication doses, adding care team contact information, and using refill reminders. For engagement, the following were statements in which participants rated using that 5-point Likert scale as mentioned previously, from strongly disagree to strongly agree. For example, the MMS Plus app gave me information in an interesting way, is appropriate for teenagers with CF, takes too much time to learn, takes too much time to use each day. The median score for both patient and caregiver was 4. And again, as a reminder, we defined feasibility and acceptability as a median score of 4 on the 5-point scale. And here are some selected statements from the semi-structured interviews identified by qualitative analysis. I thought it was pretty cool, but I really didn't use it all that much. Like I said, I was already on top of all of my stuff. It would be more useful for like a new diagnosis. For usefulness, the following statements were provided for participants to rate on the Likert scale, and patient participant median score was 3.5 and caregiver was 3.5. And again, some selected statements from the semi-structured interviews. For example, I don't forget anymore because it comes right away. On time, the notifications. So I just know that's when I should take it. I'm pretty on top of my stuff most of the time. So I wouldn't say that helped me a ton, but I can see that it would help some kids for sure. For functionality and use, the following statements here on the bullets are those that the patient participants and caregiver participants were asked to rate on that Likert scale as mentioned previously. The median score for patients was 3.75 and caregiver 3.38, with the following selected statements from semi-structured interview. For example, I'd maybe make it a little bit more user-friendly. Like I said, couldn't figure out how to, within the app, select which medications that I didn't take. So yeah, maybe make it a little bit easier to use. I feel like the app itself was pretty easy to use. It had stuff that is useful to me. For aesthetics, these were the following two statements that were provided to participants to rate on a Likert scale. Was laid out in a way that worked well for me, was organized and easy to use. And again, some selected statements from the semi-structured interviews to kind of give this perspective some context. I like the option where you were able to go in and you could select a photo and set that for the medication, a picture of the pill bottle or whatever. I liked you could lay it out where you could visually see which medication was which. Regarding information, these were the following statements that were provided to participants to rate on the Likert scale. For example, had information that was relevant to me, helps me learn new things about my medications, with a median score of 3.75 for patients and 3.6 for caregivers. And some examples from our semi-structured interviews, some statements. I think it helped me understand a little bit more about each medication I was on, kind of, a little more detailed information. My schedule for MMS was great for referencing my medications because it was always with me and it could be constantly updated after each appointment. I was able to communicate with different teams. Regarding satisfaction, the following items were asked to be rated on a Likert scale by both patients and caregivers. For example, I would like to keep using the app. I'm willing to participate in a future study that uses the app. And some statements from the semi-structured interviews. It was really good. It was a good experience. I'd recommend it to anyone who's like me, who's not fully aware of what medications to take and all. So it's a really good app. It's very helpful. It was set up perfectly, but it's just not something I would use. Here we have the summary of the IFAQ scores across the different subgroupings within the IFAQ. As you can see here, that we found that the app was engaging and it was relatively well laid out, but that the app may not be as useful for those that maybe already have a set routine, but maybe best suited for those who have need additional help in setting up a routine. For example, those new to daily care with CF, or may have new medications added to a regimen. And yet participants appear to be willing to continue using the app, and were likely to recommend it to other people with CF, and were willing to participate in a subsequent study of the app in care. Again, we defined feasibility and acceptability as a median of 4. As you can see here across the board, that we were close or met our defined feasibility acceptability with the threshold. However, there were the aspects of usefulness, functionality, ease of use, and information, again, applying towards those that may be suited better for those who already don't have a set routine, or maybe new to diagnosis or new medication or change of routine. As with any study, there are limitations to consider. This was a relatively small sample size as it was a pilot study, and the challenge of randomization within centers was something that we also learned from this in terms of having within each center randomization, meaning those who are on the app, those versus those that were not, and how that may have impacted care workflow. And as such, during the pandemic, as the study was conducted partially during that time period, there were some research challenges due to the pandemic, including device distribution and clinic visits. There were also some beta features added to the application during the study, which weren't incorporated at the time, given that they were beta features, but may have been helpful to clinicians and patients alike, including EMR integration and communication features. So the MMS Plus we found was perceived as engaging and that users would recommend it to others with CF. However, it wasn't necessarily universally seen as useful for providing education or improving adherence. And it may be best useful for those that are new to daily care with CF, have new medications, or have a change in their routine. There's ongoing data analysis from the overall study, which we hope to present in future sessions. And as far as future study considerations, perhaps we were thinking a shorter duration or possibly focusing on those who may benefit from it most. For example, again, those new to daily care, younger who are establishing a routine, or those with new medications or regimens. So when considering an mHealth application in CF care, it's important to evaluate stakeholders' perspectives, of which I think we accomplished using a quantitative and a qualitative approach. First and foremost, I want to thank persons with CF and their caregivers, for which we have the honor and privilege of working with them every day and the ability to complete studies such as this. And then the following individuals, Dr. Corey Dades and Kristen Reichert, for their mentorship and guidance throughout the study. The individuals listed here from the data management core, of which critically contributed to the study core team led by Dr. Greg Sawicki, and the site PIs listed here from the various sites, of which the study would not be possible without their collaboration and contribution. Thank you so much for all of your support, and I appreciate the time and speaking. Thank you.
Welcome back. As a reminder, please continue to enter your questions throughout our session into the Q&A box. You just heard from our second speaker, Dr. Hannah Fan, on use of a mobile medication reminder app to promote medical regimen adherence. Dr. Fan was formerly at the University of Arizona, but we're glad to now have her with us at the University of Michigan. Dr. Fan, thank you for your diligent work in finding ways to help individuals with CF to organize their daily routines. We have a few questions for you that are popping up.
Great.
And the first one is, are there separate parent-child accounts linked so parents can see what their child has done? And a follow-up question is it offered in Spanish?
So caregivers and parents can actually have the accounts linked in a sense that they can see what's mirrored on the child's account as well, I believe. Although when at the time of using the app, I think it was primarily a lot of the patient participants, the children themselves, kept it on their own devices. Some of them had it on their parents' phone or maybe on their iPad. And so it kind of varied on how they used it. It is available in various languages, including Spanish.
Great. That's awesome. Makes it much more useful for families. There was a question about any fee attached for the app to download.
So there is no fee on the patient side or caregiver side. If you wanted it to have the ability to use the clinician web interface so that the clinician can enter medications, there is a fee associated that's usually by center and the number of users or clinician users that are associated with it.
Thank you. Did you know or ask if patients were already using another mobile app to manage their CF care and whether what their thoughts were with that compared to the MMS?
So we did ask at baseline their previous experiences on mobile apps as part of baseline data. We did exclude anybody who actually used this particular app prior to the study for obvious reasons. And I don't believe a lot of folks were using medication management apps per se. I'd have to relook at the specifics on the baseline data for that, but we did ask kind of like where they were in terms of their comfort with technology in that respect.
Thank you. Another question, do you think that continuing to use more of a general medication app, not specifically for CF like the MMS, is the best direction? Or would it be potentially more beneficial for CF patients to have something developed specifically for CF that might already have the medications or be easier with the interface for them?
That is a great question. We actually tailored for this particular study for CF. We actually had a template medication list, including best therapy and other airway clearance devices as part of the template used by the study centers to make it a little bit more CF focused to help facilitate that. And so we actually created that template, and then anything associated with that template, such as the purpose and the dosing and everything, was reviewed by our study PIs and our group so that we were all in agreement at what would appear. So we kind of tailored it in that sense. I think, having something that's tailored for CF is very important because we do have a wide variety of medications and therapies and approaches. But persons with CF are also on other medications for other indications as well. So having a very well comprehensive encompassing application would be helpful that has the ability to tailor for certain disease states such as CF.
Great, thank you. You have a comment that this would be very useful for folks that have trouble remembering when to take all of their medications. So some positive feedback for sure. Based on your preliminary data, do you have a sense of which CF patients may benefit most from using a medication reminder app? And was there any difference in acceptability between patients and their parents?
So as you saw from the median scores, they were somewhat similar between parents and the patients and the caregivers. I think that's what you intended. Is that correct? So they were somewhat similar, but from our semi-structured interviews, some of the quotes and things that when we reviewed it, it sounded like our caregivers kind of had our patient participants kind of take the role and the lead on using it. And caregivers kind of were like, not as, I wouldn't say involved, but tried to allow for self-management and self-engagement. And so as far as like the folks most suited for this particular app, feedback that we got was that for newer diagnoses, a lot of times folks had mentioned that patients who may have a little bit more challenge in terms of a complex regimen and getting schedules correct. And then there was some mention of like if a new medication or new therapy was added to a treatment regimen, that this would be a good time to introduce it so that a person could kind of develop that routine.
Thank you. Yeah, I think that speaks to how important it is to get that feedback to know who to target it to and kind of what they're looking for. So thank you so much, Dr. Fun. That was a wonderful presentation.
Thank you.
Our next speaker is Dr. Virginia O'Hare, who's going to be talking to us about an adaptation of ACT with CF for adolescents and family members of individuals with cystic fibrosis.
Hi, I'm Virginia O'Hare, and I'm here with our ACT with CF Adolescents and Families team. Let me bring up our slides. And we're delighted to see you all. Wish that we could be here in person. Hopefully for next year, we'll all be together. So our disclosure, my disclosure is regarding the Boomer Esiason Foundation. They have generously funded our team's 3-year ACT with CF adult multi-site RCT. And also they have awarded us a smaller pilot grant for the current study, the ACT with Cystic Fibrosis Adolescent and Caregivers Pilot Study. So here's our team who you'll meet across these next 15 minutes. And I want to give a special shout out to Katie Lawless, our CF patient representative, and Grayson Shipman, our CF adolescent representative, who is also an author on our teen manual. So what is ACT? ACT is a new form of CBT created by Steve Hayes with the goal of increasing psychological flexibility through acceptance of painful inner experience. And the goal is to move towards our core values, what you want to be about in life, despite anxiety, illness, and other obstacles. ACT helps people live the life that they want without struggling with their inner experiences. And it's an empirically supported treatment for a variety of issues, including anxiety, pain, HIV, drug addiction, and others. All right, so our pilot study was a 3-year feasibility study of 30 CF adults who got our 6-session manualized ACT with CF intervention. And they could choose telehealth or in person, and 24 out of the 30 chose telehealth, with no differences being found on any of these outcomes between in-person and telehealth. So ACT reduced anxiety and depression with a rebound in anxiety by the 3-month mark. And ACT also reduced cognitive function, which is rigid attachment to your thoughts as truth. And so this inspired us to launch this larger randomized control trial, 100% via telehealth, of ACT versus treatment as usual, to see does ACT work better than just talking to someone. And this is the study that Heather's going to tell us a little bit about, generously supported by the Boomer Esiason Foundation.
Yes, thank you, Virginia. So this study was coming after that feasibility study. So it's the same setup where it's a 3-year study. We have the same groups of treatment as usual and ACT. The entire study was done by telehealth, which ended up being very helpful during COVID. And so our target group that we're aiming for is to have 210 patients across a multitude of sites, which is how all of us came to be working together. And each patient receives 6 sessions, that same manual that was in the pilot study, and we are currently in year 2 of 3 years. And now Patrick will tell us about the adolescent version.
All right, so you can go skip to the next slide. So the version we're doing with this for the adolescent group is very similar in terms of the outcomes and the process measures that we're getting. What we're focused mostly on looking at changes in depression and anxiety, but also including some measures of parental stress. You can go to the next slide. For the psychological process measures, it's very similar. What we're looking at changes in cognitive fusion and acceptance, but we're also looking at some medical compliance related behaviors. So like adherence to medications, attendance at scheduled visits, and other kind of patient-rated outcomes. You can go to the next slide. And then we're going to use a very similar analytic setup to what we've done in the past, where we use this model that was derived for FDA studies, where you're combining the outcomes in a kind of a gatekeeper step, and then looking at where specific treatment changes may have occurred in individual measures. And we'll also do some biobehavioral outcome measures of things like hospitalization. The setup of this study in terms of the study flow is very similar to the other studies as well. There's a baseline assessment. People are randomized for 6 weeks. And then there's post-treatment and follow-up assessments that occur over the next few months. And I can turn it over to Darcy.
My name is Darcy Esiason. I am a child and adolescent psychotherapist and also a CF spouse. And I'm going to tell you a little bit about what's new in our Teen ACT intervention and how we adapted the manual to account for the teen experience. The two most important things that we focus on when adapting the treatment for teens were, one, we wanted to ensure that we were coming at the manual from a developmental perspective. Anyone who works with teens or even knows a teen knows that the underlying psychosocial needs of a teenager revolve around finding their identity, flexing that identity, trying on new identities, feeling insecure about that identity, and then overall starting to define the direction that one wants to go in life and who you want to be. The second thing we really wanted to focus on was that even though the psychological burden of being a teen with CF has a lot of overlap with that of adults with CF, there's also a whole lot of stressors specific to teen life. So we wanted to account for things like going through puberty and changing body image, school, social media, suddenly having an interest in romantic partners, the huge pressure of fitting in, the role of friends versus family, striving for independence, and kind of all those stressors of adolescent nature. And we also feel that the ACT intervention is prime time for teens to almost catch them before they go down the paths of anxiety and depression that are so common in adulthood, and give them the skills to cope with CF and start that value-based living before they really, really need to have those skills. We were also really aware of making the treatment accessible and easy for teens, and one way that we're accomplishing that is by having a smartphone app to go along with the treatment. So now you'll see the cover of our manual. The theme is different than the adult manual. You can see that our theme for teens is paddle on, and it means always being in motion in the direction of your values, even when there are all sorts of obstacles in your way. And we changed quite a bit of the experiential parts of ACT to adapt to our teens. Now, there are some kind of basic easy changes. So one example would be in the adult manual, to get at values, we ask, what would you want people to say about you at your 90th birthday party? And instead we swap that for, what do you want people to say at your 25th birthday party? And that's because teens are a lot more short-sighted than adults. And then there were some changes that go into the training of clinicians. So one example of what that might look like is having our clinicians be prompted more often to check in with the teen about if their values have stayed the same from session 1 to session 2 to the later sessions, and then validate that it's totally okay for values to change, because developmentally adults are more likely to have an idea of what they want to be about, but we know with teens that things that are important to them might change week to week. And then we have the addition of some ACT skills that aren't included in the adult manual at all, like LLAMA, which is an acronym for how you can tackle a barrier or a problem that comes up and tackle it in that moment. And we have a silly picture of a llama, and it's also part of the app. So teens can learn skills like llama-ing in session and then use their phone during the week to put that skill into action. And like Virginia said, we had an awesome teen, Grayson, consult with us. And the way that we had him consult, we basically gave him a beefed up version of the intervention, so he could pick and choose which parts of the intervention resonated with him, which parts didn't resonate so much, and then offer feedback on how we can make some of the language and metaphors more teen friendly. And then we have a caregiver component that Chris is going to tell you more about. But final slide about the app. The app is pretty awesome. The way it works is that the skills that you learn in session then get unlocked in the app that same week, so you could practice them during the week and then even after the therapy's over. But now for Chris to tell us about the caregiver component.
Hi, I'm Chris Drescher. I'm a clinical psychologist from Augusta University, and I helped develop the parent manual that was used as part of this intervention. We knew we didn't want to completely change the intervention and make it a family intervention. So while there were a lot of adaptations, we wanted to keep it focused on individual therapy with the teenager with CF. But we also realized that family context was very important, and it was important to include the parents in some way. So that's why we developed this parenting manual. The idea is it's a way for the parents to sort of follow along on their own each week with what the adolescent is doing. So the manual includes content that really mirrors the adolescent session that they'll be working through with their therapist. And this content will include some self-reflections for the parents on their own emotions and behaviors, as well as things specifically related to parenting. And then each week, there's also some ideas for some shared activities that the parents can do with an adolescent. And importantly, the parents don't get any feedback about specifics of what the teenager is saying in session. This is completely separate. And based on feedback from the parents focus group, we realized it was going to be important to have a little bit each week about how to work with siblings. We know siblings are an important part of the families when one child has CF and maybe the others don't. So we do include a small sibling circle each week, which gives some ideas about how to engage siblings, as well as information about other resources if a sibling is in need of more extensive services. And I'm going to turn it over to Chelsea Nurse now.
Hi, so currently we plan to recruit participants from the following sites. And while our primary plan is to recruit in person, due to the COVID-19 pandemic, we also plan to recruit participants via social media. Next slide. So eligible participants include adolescents ages 13 to 19 with a diagnosis of CF and one adult caregiver or family member that is willing to participate in the intervention. And individuals will be screened for eligibility using both the PHQ-9 and the GAD-7 and the BDI-2 and the BAI to maximize the likelihood that patients experiencing clinically relevant symptoms are detected and referred to the study. The main exclusion criteria for the study include a history of suicidal attempts or acute suicidal ideation, presence of psychotic disorders or symptoms, and anything that will interfere with the participation in the study. Finally, some frequently asked questions. The therapy administered as part of the study is completely free of cost, and participants are compensated a total of $100 for completion of study measures. Participants will receive 6 weeks of telehealth administered talk therapy, ideally 1 session a week, but we're pretty flexible, and sessions are 50 minutes a session. And they're administered by master's level clinicians who have undergone training in the aforementioned Act with CF manualized protocol, and all referrals can be directed to either Dr. O'Hara or myself.
Thank you. Thank you, team. So I just want to leave this slide up for just another moment in case anyone wants to refer a patient to chelsea.nurse@jefferson.edu. So we'll leave that up. And thank you for watching our presentation. I wish we could have been there in person. Send us your adolescents with CF. We can't wait to see whether this treatment helps them in the same way that it helped their adults. And I think we've really beefed up a great team and a great treatment, and we're looking forward to see what shakes out. Thank you.
Hello again. You just heard from our third speaker and her team for the novel virtual psychosocial interventions workshop. You've likely heard Dr. Virginia O'Hare and her team present on their work on acceptance and commitment therapy in previous NACFCs. And we're so excited to have them present on modification of this promising intervention for adolescents and family members. Dr. O'Hare, welcome.
Hi, thank you so much for having me.
Yeah, thank you for a great presentation. I loved how you incorporated your team into that. That was great.
So full disclosure is the way it looked on my screen is all heads along the top. So I'm aware that the slides kind of got eaten, but I feel like it's worth it to see the whole team.
I'm sure everyone enjoyed it. We have a few questions for you. So starting with, can you speak to any specific challenges that you perceive in potentially recruiting teens or caregivers for study participation versus your previous work with adults?
Absolutely. So, and as you're well aware, because I know I was updating you all on an almost weekly basis to say, we still have no participants. I still have no data. Are you sure you want me to talk? So I think partly what we ran into is we started recruitment for this pilot study in June of this year, when we're right kind of in the throes of like the hot vax summer of like the teen vaccine had come out, for COVID, and we actually recruited 0 participants until school started in September. And since then, we have had a few trickling in. Now, for the pilot, we're not trying to get a whole wide ton because we are planning a second arm of a randomized control trial similar to our adult study. So we'd like to, really test out in the pilot like a feasibility handful of like 10 participants, and we're on our way in that direction. So since school started, we are getting people referred from our usual sites and from social media, but certainly the kind of poor turnout over the summer gave me great pause, although I really think it was sort of an artifact of this time of year.
Yeah, I'm so glad to hear that things are picking up for you, because I'm sure it'll be a very useful intervention. Do you have any feedback so far on user experiences with the app?
Yeah, so we've beta tested it, so it hasn't launched for the world. It's only in kind of beta testing for this pilot. And certainly we found that favorite components seem to be recording your own voice that then you can play back for our diffusion exercises. So anyone who's been to one of our ACT trainings knows about diffusion, like saying a word that haunts you, like transplant or cough, over and over and over again. Silly voices, silly accents, saying it until it becomes just kind of meaningless sounds. And that's a feature that the app does really nicely.
Great, thank you. One question we have, it seems like a lot of content for 6 sessions. Do you have feedback based on your previous work on acceptability of the kind of amount of content that's in that small amount of time?
Yeah, absolutely. And the sessions really are only 50 minutes, right? And we have a rule for the trainees that anything you don't get to, you don't roll it over for the next one, you just keep it moving. So there's never kind of a backlog of information, and it's much more important that the teen understands the concept than that everything is covered. So each session will focus primarily on one ACT concept. For example, identifying values. The next one might be barriers to moving towards your values. The next one is committed action in the service of your values. And as long as the general concept is understood, we're golden. So there'll be lots of little interventions throughout. And at the same time, if the teen's getting it on intervention 1, if none of the rest of them happen, that's also fine. So we have kind of, when I do training with the clinicians, we prioritize, here are the 3 things you have to hit on in order for this session to be considered adherent, because we do plan to code the sessions for adherence as we do for the adult study. And then there's extra for, if a concept's not going over well, we've got other metaphors to sort of get at the same thing. But overall, just keeping with ACT philosophy of being very flexible and workable. So if the teen gets it, great, moving on to the next concept.
That's great. I'm sure the flexibility is really useful with teenagers, especially. Do you have a protocol if you come across anyone with suicidal ideation? Would they remain in the study, or would there be other procedures for them?
Yeah, that's a great question. So kind of in my other life outside of CF, I am a dialectical behavior therapy, DBT clinician. So I have a lot of experience working with adolescents and adults with active suicidal ideation, including chronic suicidal ideation. So if at the intake, it's found that the teen has, really elevated suicidal ideation, which is, usually endorsing item on the BDI, item on the PHQ-9, then at that stage, we would get probably me or another study clinician involved to figure out, is this a good match? Once the person's in the study, we would then certainly link them with resources. So everyone is coming either from one of our major recruitment centers, in which case, they have access to the mental health coordinator at that center, or even if they're coming from social media, we make a bridge to whatever their CF center is, and we can be in touch with those people. So we haven't yet had, in either the adolescent or the adult study, we haven't yet had anybody who had to be excluded mid-study for elevated suicidality. And again, if that did happen, we would have to make a sort of case-by-case determination, although I'm always of the frame of mind that it's best to add on during times of suicidality rather than take away something that could hopefully be life-saving, like figuring out what you want to stand for, what you want to be about.
Yeah, it's really nice to have that extra team support, to have those connections with their primary CF teams for things like that. So there was a question more practically at this point, since the teen manual is not available, is it appropriate to use the adult manual for teens until the teen manual might be available?
I mean, there's so many changes that we've made. And I'm hoping, it doesn't feel right to send out the teen manual now, because I do want to test it on like at least 10 folks. And because it's constantly kind of a work in progress. Like we tweak things based on patient feedback. Like I just a few weeks ago got feedback that a couple of our teens, like Darcy had mentioned during the recorded component, not only were their values changing much more week to week than we would expect in the adult sample, but just even the concept of values seemed a little amorphous to two of our teens. So thinking about, do we want to revisit values more frequently than we would in the adult manual? So I guess I would say, in the absence of a teen manual, sure. I mean, the adult manual is not going to hurt. And at the same time, we relied on various great ACT with adolescent books that, would be great to also read to modify the adult manual in your own way. But hopefully the teen manual will be coming to you any month.
Yeah, we'll definitely look forward to that. One other really quick question: where are you accepting participants from? Is Canada an option?
No, so I'm Canadian from Toronto, and I went to undergrad at McGill in Montreal. And it is heartbreaking to me whenever we get a Canadian, I guess applicant, and we have to say no. So unfortunately, no, we're taking all comers from the States. And right now we're taking 0 comers from other countries. And that's really just because of like IRB and, practicing across, we're not delivering a therapy, we're delivering a, study intervention. And at the same time, it's currently seeming too complicated to involve other country sites. That said, I would love to be able to help out our fellow Canadians. So stay tuned.
Yeah, we'll look forward to that in the future, as well as the results for hopefully our next NACFC. We'll hear more about it.
Which is here in Philly, in my hometown. So hit me up. Next NACFC, party's on.
Yeah, thank you so much. It's great to hear from you and your team.
Thank you.
Up next, we have Miss Elizabeth Jorgensen, who's going to be talking to us about a virtual CF support group for adolescents during the COVID-19 pandemic.
Hello, my name is Beth Jorgensen. I'm the social worker from Atrium Health Living Children's Cystic Fibrosis program. I'm going to be talking to you today about creating a virtual CF support group for adolescents during the COVID-19 pandemic. There are no relationships to disclose related to this presentation. The challenges of managing and living with a chronic illness such as CF place individuals at higher risk for mental health issues, isolation, and loneliness. Problems such as depression, anxiety, and isolation can negatively impact adherence to prescribed treatments, physical health, role functioning, and quality of life. Studies have shown that virtual and face-to-face peer support groups can play a role in reducing social isolation and creating a community where feelings and experiences can be normalized. Given that infection prevention guidelines recommend that all people with CF should be separated by at least 6 feet, the ability to adopt a virtual platform becomes vital. Previous studies have demonstrated that an online setting enabled a physically disconnected group to connect and create a safe space to collectively share experiences and receive support to manage and live with CF. Participants exchanged advice derived from experience and views on how to manage treatments, emotions, relationships, identity, and support from services. The support young people desired appeared to be more directed at how to fit CF into their everyday lives. So in late 2019, we decided to set a division goal of creating a virtual support group for our CF teens. Our QI coach, psychologist, and myself began to meet and start planning. As everyone knows, early in 2020, the COVID-19 pandemic hit. Now there was an even greater need to connect these individuals who are even further isolated due to schools being closed and individuals being required to quarantine at home. Thankfully, an IRB was submitted previous to the COVID pandemic hitting for Research versus Quality Improvement Project. Once COVID-19 hit, all submissions were put on hold that didn't directly relate to the pandemic. Our IRB was approved for a quality improvement project. Probably the most time-consuming part of getting this project started was creating a consent form. We looked and there weren't any consent forms that specifically met the needs that we needed for our group. We did meet with a group from oncology that was doing their own group for parents of patients. And they shared with us the consent form that they were using. We were able to create our own and send it through the Health Literacy Council, who reduced the health literacy level from a 12th grade to 9th grade level. We also sent it to our hospital legal team for approval. We had patients and parents sign the form and include their contact information. If you'd like to scan this QR code, you can get a copy of our consent form so that you can use it instead of having to start from scratch like we did. So next, we needed participants for our group. We asked 14 to 18-year-old patients with CF while they were in clinic by email and by phone. We decided to have 6 sessions that would last over 3 months, meeting every other Tuesday night from August to October of 2020. And we used the Microsoft Teams platform. For data collection, our goal was to decrease isolation and loneliness within these individuals, as well as looking at their overall mental health. We decided to utilize the UCLA Loneliness Scale, PHQ-8, and GAD-7. In addition, we also had satisfaction surveys that included questions like how did you think group went, what would you like to do differently, etc. Our goal was to have all of these surveys completed before the first session, as well as at the completion of the last session. In addition, we also aimed to administer the PHQ-8 and GAD-7 after every other session. If you're thinking that this sounds like a lot of surveys, you are correct. I should mention our QI coach compiled all of these through REDCap, sent them out via email, and she was the one to evaluate them so that they would stay anonymous. So now it was time to start group. We emailed parents and patients reminders before each group. The groups were co-facilitated by myself and our psychologist. Each group included an icebreaker to be able to help build rapport between the patients, as well as getting to know each other on a more personal level. Each group focused around mental health topics, facilitated discussion, and open conversation. We also invited an adult with CF to be our guest speaker at one session. Here you can see what each week looked like for our group. I'd like to point out that session 5 and 6 were our psychoeducational groups. We felt an obligation to talk about anxiety and depression, especially during the global pandemic. We provided education, warning signs and symptoms, brief interventions, resources and apps that could be utilized. We plan to do this during session 5 and 6 in hopes that by the time we got to the end of our group, the participants would feel more comfortable with one another and also feel more comfortable talking about such a sensitive topic. In retrospect, ending our 6-session group talking about depression was probably not the best idea. We had 5 participants, 2 females and 3 males, ranging from age 15 to 18, 4 in high school and 1 that just started college. It was a nice dynamic to have a college freshman join, as he logged in from his dorm room and was able to share experiences of starting college and navigating the COVID-19 pandemic. Attendance varied from 2 to 5 participants. As much as we wanted everyone to participate each time, when there were 2 patients, it was surprisingly a nice change where those 2 people could really share and get to know one another on a more one-on-one basis. Probably not surprising to anyone, our survey results were incomplete. There were several people who only answered a couple surveys, several who did none, and one, I believe, that did all of them. So we had a very low response rate. In addition to that, we realized that we weren't even measuring what we wanted. Those who did complete the UCLA loneliness scale didn't report feeling isolated from their peers, but through conversation and group admitted to feeling isolated specifically regarding their life with CF. Because we did not have complete surveys, our QI coach and myself facilitated exit interviews. These were done one-on-one, or rather 2-on-1, and recorded on Microsoft Teams and then evaluated. The average overall satisfaction score was 4 out of 5. They reported enjoying the adult speaker and were enthusiastic about resuming the group. For structural feedback, they agreed on 30-minute sessions, comfort being called on, and scheduled topics were acceptable. They enjoyed free talk, and preferences on group size and meeting frequency varied. Now, through the evaluation of these interviews, we identified a couple themes. The first was self-identification with CF community. Following is some direct quotes from our participants. I'm a social person, and you don't get to be social with other CF people, so being able to have that interaction is really nice. I didn't really know anybody with CF. Gives you somebody to talk to that knows what you're going through, stuff like that. Speaker sharing that she didn't feel like doing her treatments, and I wasn't diagnosed until 13, so it helped me to take more initiative with my treatments. The next was self-validation by CF community. It helped me understand that it wasn't just me, made me realize that there were other people in the same boat. It was nice to hear what other people said about it and know you're not the only one that gets sad sometimes and things like that. It was cool seeing that the other people do the same stuff. Talk to others my same age that are going through the same thing, sharing feelings and fears, talking about how people act when you tell them you have CF. One of our participants was kind enough to share her experience with the group.
Hi, my name is Riley Pyle and I'm 17 years old. I participated in the virtual support group and I really enjoyed it because it helped me to connect with other teens who also have CF. I was able to talk about my feelings, my worries, and even questions I had regarding my future. Occasionally I would think to myself, oh, they're probably judging me right now, but they weren't, because at some point in their lives, they had also been through the same thing and they knew exactly how I was feeling. Before this group, I was embarrassed to tell people I had CF. I just really didn't want anybody to know. But with help from this group, I've learned to take on my fears and embrace who I am, because CF is what makes me unique. I would definitely recommend a group like this to any CFer who feels alone or misunderstood. It really helped me a lot, and I think it would help any CFer out there as well. Thank you.
Okay. Lessons learned. First, our successes. Utilizing icebreakers was a great way to start our group. It helped people to laugh and get to know each other in a non-threatening way. Conversational prompts were very effective. Even though patients said that it was just acceptable, if we didn't prompt them to talk about how school was going, how they felt about COVID, or sharing about their CF, they probably would have just sat there and stared at one another. Calling on participants. All participants are not created equally, and that's okay. Some were much more eager to engage and share their experiences, while others were a little bit more quiet and shy. And for those, we would call on them to share what they were thinking and feeling. And as you could see in previous slides, everyone reported feeling fine with being called on. Alternating leading the group between the psychologist and social worker. It was helpful to have every other week to be in charge of figuring out the icebreaker and the lesson plan for the day, as well as being the head leader of that group to reduce some of the burden of facilitating this group. And then lastly, inviting an adult with CF to share their story. This was probably the most impactful part of our 6-session group. Areas of improvement, and there are a lot of them. First of all, different survey questions, preferably ones that are eliciting the desired feedback. We've discussed using the CFQR, which has specific questions for the CF population, and taking out specific questions. For example, to what extent do your treatments make your daily life more difficult? I feel comfortable discussing my illness with others, etc. And then doing PHQ-2 and GAD-2 to hopefully decrease the survey burden and get more specifically at what we're looking for. Email was an ineffective communication method. Teenagers never check their email. So despite emailing them, it was not effective. And they recommended trialing other communication platforms like GroupMe, so we can send our reminders, send the surveys, and also hopefully have conversation between our groups. Administering surveys during group to ensure completion. So we will still send out the links in advance to complete the surveys, but for those who don't, allowing time in the beginning to make sure that they are completed. And probably not a surprise to anyone, but patients reported they didn't enjoy the psychoeducational groups that we held based on depression and anxiety. They reported that they were awkward and uncomfortable. So as much as we felt like it was an important topic to discuss, they just wanted to come to group to be able to connect with others and casually talk. Our next steps are recruiting new members for our teen group. Many of our members have transitioned to the adult clinic, so we need to recruit additional people. We're getting consent signed and hope to start this fall. We would also love to expand our group to the middle school age and also parents of newly diagnosed patients. These are our references. And are there any questions? Thank you for listening to my presentation.
Welcome back. We're now in our 4th question and answer period. Please continue to type your questions into the Q&A box throughout the session, and you can also upvote any questions that you particularly like. We're pleased to talk with Beth Jorgensen from Levine Children's Hospital in Charlotte, North Carolina. Ms. Jorgensen, thank you for all your work in educating us on how to start a support group for individuals with CF. I think it's so important right now, especially to have those social connections between people. We have a few questions for you. How would you recruit and convince those people that are reluctant that would be helpful to participate?
That's a great question, and definitely something that we struggled with. So I think what we learned was the most effective way was approaching patients and parents in clinic. Like I said, we also did it by email and phone, but actually able to have those conversations in clinic, and just telling the kids, like, please just come for one session, try it. If you hate it, you don't have to come back. But most of them, I think, were just really nervous about the unknown of it. And some were excited to try it. So what I've noticed since then, though, with trying to recruit for our subsequent group, that there's a lot of resistance. So I think just being face-to-face and also doing it with the parent present, because then the parent can also encourage them. And if the parent's on board, then they're going to remind them and help them get online for that group. So just begging and pleading and trying to tell them that everyone feels the same way they do and is hesitant about it, and just to give it a try.
Thank you. Yeah, recruitment seems like half the battle. I think we're having a theme of difficulty with recruiting adolescents for these projects that can be so helpful for them. Was there a particular structure you used for every support group, kind of a format, overall format? And then how long was each group session?
So each session was 30 minutes. The one where we had the adult with CF as a guest speaker ran a little bit longer than that, but the plan was for 30-minute sessions, and that seemed to be a good time frame. The structure was just pretty much getting on, having small talk and doing some icebreakers. And then the first 4 sessions, well, one we had a guest speaker, so those other 3, we just came up with different conversational prompts just to get people talking, and they really enjoyed sharing their individual experiences with CF, but that wasn't something that they were forthcoming about. So just prompting them, how do you fit your treatments into your day and things like that. And then, as you saw, our last 2 sessions were more psychoeducational. And so we did have, information about interventions and resources, and people weren't as engaged in those sessions. But that was sort of how we structured it.
Yeah, you learn from your groups for sure. You learn what to do next. Did you have any kind of screening process to identify participants or people to approach? And then do you know what percentage of eligible patients actually signed up to participate?
So anyone was welcome that was of high school age. We wanted to target this first group to be high schoolers. As you heard me say, we did have one college student. We started this group in August, so he was just starting college. But as I said, that worked out really well. So anyone and everyone that was ages 14 and up that were in high school were welcome to join. And we got 6 people that signed consents, 5 that actually came to group. And I would have to look back at our population to see what percentage, but it was a small percentage. Like we've said, it was difficult getting people to agree, but I was excited that 5 out of the 6 people that signed consents actually did attend group.
Yeah, that's great. Once you get them on board, they're attending. Can you speak to any lessons learned about the technical experience with holding a virtual group? Did technology seem to be a barrier for anyone? If they couldn't participate because of technology barriers, or they had issues with their technology?
That actually went very smoothly. I think teenagers in general are very tech savvy, and because at this point we were at least 6 months into the pandemic, so they were used to doing virtual for school. So we had no issues with that. Our first session, all 5 participants came, they had their cameras on, they didn't have any audio issues. So I didn't have any experience with technical difficulties. So that was nice. Worked out well.
Yeah, teenagers were probably better than most of the adults. So we have a question about discussing confidentiality, which I think comes up a lot with support groups. How did you discuss that with patients and then also with their parents before the group started or during the group?
So as I said, we had them sign the consent form and we approached them during clinic. So we were able to have those conversations through that process. And then also the psychologist and myself had a conversation with the participants during our first group. So that's when we were able to explain and address confidentiality.
Thank you. I think it's great to hear the lessons learned from your experience. And I really enjoyed hearing from one of your participants about her experience for sure. And one comment was that our listeners really appreciate the hearing from the exit interview feedback and the patient videos I just mentioned. That was it was nice to hear her talk about feeling a better sense of community after participating in the group.
Yeah, it's actually really awesome because I think she got a lot out of the adult with CF, the speaker that we had. And since then, this year, she's been advocating about mask mandates and COVID. She's been on her local news and in the newspaper. So she's just been really an advocate and wide open about her diagnosis. And you can tell that she's really grown into more of a comfort around that. So that's been really great to see.
That is so great. Well, thank you so much for talking to us about your experience. And I think we all have learned about what we could do with support groups at our centers. So thank you, Beth.
Yeah, thank you.
For our next speaker, we have Dr. Christina Duncan, who's going to be talking with us about her telecoaching intervention to promote adherence. So we're excited to learn more about that.
Hi, I'm Christina Duncan, and I'm a professor at West Virginia University. I am happy today to present our talk entitled Protocol for a Feasibility and Acceptability Pilot Trial of a Telecoaching Intervention to promote adherence in adolescents and young adults with cystic fibrosis. The following relationship exists related to this presentation, and I'd like to highlight the contributions of my colleagues and co-authors for this talk, particularly noting my co-PI for the grant, Dr. Deepika Polaneni. So why telecoaching? As many of us know, CF care is quite burdensome for our patients and their families. We also recognize that adolescents and young adults are at risk in particular for non-adherence. Yet research shows that educational and behavioral strategies are effective at improving adherence, particularly when they target the specific or unique individual barriers that each patient experiences. We thought that telecoaching might offer a unique and flexible platform to share tailored and goal-oriented strategies targeting adherence concerns in these individuals with CF. So the overarching objective for our grant project is to conduct a study across 2 phases where we first devise and subsequently evaluate a novel, patient-centered, and practical telecoaching intervention to improve adherence in adolescents and young adults with CF. So before we talk about phase 2 pilot trial, I want to provide a little bit of context from phase 1 results. So what we did in phase 1 was essentially devise the intervention. So we enlisted key stakeholders from 5 different CF centers across the US to participate in focus groups or individual qualitative interviews via video conference, depending on what their preference was. We included 31 adolescents and young adults across the ages of 14 to 25, and we engaged 20 CF care team providers across a variety of disciplines, including physicians, nurses, social workers, and psychologists. We had 11 caregivers or parents of adolescents with CF as well. The first interview was essentially set to obtain perspectives on the design and content of our telecoaching intervention program. So we were asking questions like, who serves as the coach? What type of skill sessions might we need? How frequent should those sessions be? And how long should the intervention last in general? From that data, we conducted a thematic analysis and used those themes to help devise what the intervention was and develop the structure and content for all the individual sessions. We created a summary document of the session content and associated activities and worksheets as well. This took us into the second interview with these same stakeholders, where we first shared that summary document, and then we subsequently elicited their specific feedback to help modify and refine the intervention and the module content. So you see some sample quotes below depicting some of the details and thoughts that were shared with us. We felt that this interview was really critical to optimize the feasibility of implementation and acceptability for our intervention. From those data, which were summarized, we finalized our telecoaching intervention manual, and we also established a plan for training the coaches prior to their involvement in the intervention as part of the phase 2 pilot trial. So that takes us to a snapshot of what the telecoaching intervention actually looks like. The coaches are a CF care team member for that particular participant. We chose not to include the physician or the nurse practitioner that might be the primary care person, but someone else on the team who partners with the adolescent or young adult to teach them skills around addressing their barriers to non-adherence. And that non-adherence might span from forgetting their treatments to choosing not to do the treatments, or perhaps not doing them as prescribed. The intervention is characterized by individualized coaching sessions that are conducted via video conference for 6 months. The first 9 sessions occur every other week for the first 4 months, and then we have 2 monthly sessions thereafter. We decided to use the CF Care Behavior Survey, which is a questionnaire to guide the actual intervention approach for each specific participant to take them through the intervention. This survey is structured so that it has sections for each CF treatment component, such as CFTR modulators or airway clearance. It uses branching administration such that if the individual's not been prescribed that treatment component, they move to the next one, or if they don't endorse any adherence concerns, they can move to the next treatment component as well. It is designed to measure inadvertent and volitional non-adherence, as well as the unique barriers that individual has to that adherence, and their motivation to improve adherence for that particular treatment component as well. The CF's Care Behavior Survey is administered prior to the start of the intervention program so that we can identify what adherence targets or treatment components that individual wants to work on, what their barriers are, and then what the relevant skill sessions would be to address those barriers. So to illustrate the measure here, we have an example of it asking whether the treatment was prescribed, and then how well the individual took the medication or did the treatment, and then if there were concerns, what kind of barriers might apply, and lastly, scale of how important and how confident they feel about improving their care in that particular area. This slide depicts like an overall summary of what the intervention looks like. So all participants start with their first session as an introductory session to telecoaching, where the coach can establish rapport and provide an overview of what the program will look like. The second session is covering SMART goals. We felt this was important for all participants to have because SMART goals are an integral part of all the subsequent skill sessions. So everyone covers that. And then you see in the middle of the slide all the different skill sessions that are available to select from based on the barriers that the participant experiences. And these are evidence-based strategies for those particular barriers. And then the final session is a skill session, but also a wrap-up. So another part of our intervention is to train the coaches before they actually implement it as part of the study. And our training is conducted by 2 licensed psychologists who are also study co-investigators on this grant, Dr. Emily Muther and Dr. Jenny Lindwall. They conduct these training sessions through virtual platform in a synchronous manner, but we also have been able to obtain recordings of some of these previous sessions. So we also have an asynchronous format available for coaches to train if they prefer that. The training consists of didactic and experiential training components. So the first day is a content overview of all training materials, including the individual skill sessions. So it includes didactic instruction as well as review of videos that demonstrate those module skills, and includes interactive discussion amongst the coach trainees and the psychologists as well. There's a little bit of time that passes, and then we have 2 half-day sessions of experiential practice, which involves role plays involving module scripts and case scenarios so that the new coaches can actually put into place some of the skills that they've learned. Prior to actually implementing the intervention as part of the study, the coaches are required to complete an open book knowledge assessment that they take post-training and achieve a passing score before they are able to actually work with a participant. And then throughout their involvement, these coaches engage in monthly virtual supervision with the same licensed psychologists to keep an ongoing honing of their skills and to address any issues or concerns they have. So this is just a quick snapshot of one of those coach training sessions that we have had. So this leads us to phase 2 and its aims. So phase 2 is a single-arm prospective multi-center pilot study with the primary objective of measuring feasibility and acceptability of the structure, delivery, and content of our telecoaching intervention. We have a few secondary objectives, which are to examine the feasibility and acceptability of study procedures, to evaluate also the potential intervention effects on adherence and also treatment barriers across time. So our target sample consists of 48 adolescents and young adults between the ages of 14 and 25. We include caregivers in the assessment if they are involved in the daily care and live in the same home as the participant, and the participant agrees to their involvement. We're recruiting from 6 CF centers across the US, and we have broad geographic representation as a result. And we're using a phased site activation whereby we had a Vanguard site activated first and then 2 subsequent waves of sites thereafter. We are collecting quantitative and qualitative data. We utilize surveys on REDCap so that we can obtain our data remotely. We are tracking descriptively a variety of variables, including things like types of sessions chosen, adherence, reasons for dropout. We also include a qualitative exit interview with the adolescents and young adults when they finish the intervention and the coaches when they finish the study. Our primary outcome variables align with our primary aims. And so we are measuring recruitment and feasibility, attrition and reasons for attrition, as well as the adolescent, young adult, and coach ratings of acceptability and satisfaction on a survey. We have set benchmarks for each of these primary outcome variables to help us determine whether the study and the intervention itself is feasible and acceptable. We also have a number of secondary outcome variables, and this slide depicts some of the key ones. The first noted is the patient and coach feasibility and acceptability of study procedures. So this is looking at things like the number of sessions that take place within or outside the schedule window. Also have the adolescents and young adults completing between session activities and things like that. We're also measuring global and specific treatment adherence. And so we're looking at self-report of that, as well as some objective adherence monitoring data that we track across the course of the study. So we're looking, for example, smart nebulizer treatments that are sent real-time via cellular network throughout their participation in the intervention, as well as obtaining some vest or airway clearance data via photos that the participant takes of their LED panel on their device and sends biweekly via text or email, depending on their preference. And we measure change and barriers in treatment using the same CF-CBS survey that we administered pre-study, but we again administer it mid and post-treatment so that we can measure change across time. So this slide actually depicts an infographic that we used during recruitment and had created by a medical illustrator, and it shows the flow of the study. On the left, you see that we have participants engage in an enrollment visit where they're consented and complete the screening measure. If they are eligible for the study, they then get their e-tract and VEST data set up in terms of training and procedures. They complete a baseline assessment online via REDCap. And then we have adherence monitoring taking place over a course of 3 weeks to gather baseline levels before they actually then start the telecoaching program, which is shown on the right side, with our sessions taking place on every other week, as noted earlier, for about 30 minutes or less, and going to once a month. We also show on this slide the mid-study assessment, as well as the post-intervention and a follow-up assessment 4 months later. So in conclusion, our data collection is ongoing. We've made pauses, not surprisingly, due to the release of Trikafta, as well as the COVID-19 pandemic. All but one site have been activated to date. The Vanguard reactivated about a year ago, and we've had a wave of sites released this summer. We've pivoted study procedures significantly to address issues with Trikafta and the pandemic. For example, our recruitment can be done fully virtual. We also created and implemented a COVID-19 survey so that we can measure the impact of the pandemic on acceptability and feasibility of things related to our study, such as video conference use. We also shifted our coach training from originally being in person to virtual, and this also resulted in our ability to do an asynchronous training option as well. And we think this will enhance dissemination and implementation of study procedures and the intervention in the future. So far, we're getting good news, and we feel like telecoaching is looking to be a very promising approach for us to help guide adherence promotion strategies with adolescents and young adults with CF. And we look forward to sharing some of our outcomes in future conferences. And to close, I'd like to thank our sites, as well as the study cores at Johns Hopkins and Boston Children's, and of course, the Cystic Fibrosis Foundation. Thank you for your attention.
This is the final question and answer period for the NABL Virtual Psychosocial Interventions Workshop. You just heard from Dr. Christina Duncan from West Virginia University. Dr. Duncan has been working hard for some time in the development of the telecoaching intervention, and we're so excited to hear more about this. Dr. Duncan, thanks for being with us.
Thank you, Dr. Butcher.
So we have a few questions for you. The first one is the CF Care Behavior Survey an existing validated measure, or was it created specifically for this study?
Yes, a very good question. It actually was a tool that was developed before the study was conceptualized. But when we actually envisioned what we were going to do with the intervention, it was a tool that we thought would be very, very helpful. We're in the process of validating it. So we've been gathering some data, and before we actually started the first phase, we included some cognitive interviews to get some understanding of the items and its content to really kind of polish it up before we actually used it for the intervention. But we are ongoing gathering some data for validation.
Thank you. Mm-hmm. Can you give an example of one of your evidence-based interventions for a specific treatment barrier and where you found it or developed it?
Certainly. When we were developing the intervention and its manual, we looked at the literature and looked at where studies were documenting evidence-based strategies to target particular barriers to adherence. So, for example, if a participant explained that or endorsed a barrier that they just didn't feel motivated to do their intervention or do their treatment components, then we might engage in some strategies around behavioral activation to try to activate them in that way. We also would be, if like a participant expressed concerns with time management, feeling kind of disorganized, things like that, then we would apply a session around behavioral strategies to help improve organization and to help routinize some of their CF cares into their day-to-day basis. Similarly, if forgetting was an issue, we might use problem solving, things like that. So we basically tied the particular sessions to the specific barriers based on what the evidence base shows.
That's great. It's nice to have such a tailored approach too, that you're not just throwing everything at somebody who might not have that specific barrier.
Yes, and something that I wasn't able to really get squeezed into that 15-minute talk is to note that we also allow participants to have more than one session on a particular skill, so they can revisit a particular skill either immediately after one session or even later down the road in addition to or perhaps in response to a different treatment component. So a lot of time from Dr. Muther and Dr. Lindwald and the team went into really building this intervention and trying to structure it in a way that would be sort of seamless in delivering it. And so far that seems to be paying off.
Are people with CF with diagnoses of depression and anxiety included? And would you consider any adaptations specifically for individuals with mood disorders?
Another good question. This is not part of our inclusion criteria, but it's also not part of our exclusion criteria. So indeed, we may have participants who endorse symptoms of anxiety and or depression. The intervention does not specifically target mental health concerns, but as you can see in the slide that depicted the actual strategies, you can see that some of them would be the same sort of evidence-based strategies that would help to target those mental health concerns, such as behavioral activation, social support, stress reduction, those kinds of things. So indeed, I think the intervention could have some impact, and particularly when those mental health concerns are part of the barriers in terms of CF daily cares. But the focus of the intervention is really on promoting daily care in CF.
Thank you. Yeah, it's nice that people can generalize some of those strategies for adherence or for mood, especially things like behavioral activation.
Yes.
Are the coaching interventions or education targeted to caregivers simultaneously?
Currently, we are not targeting the caregivers. We basically are teaching the adolescent and young adult the skills that they need to address their barriers in their CF cares. But we are engaging caregivers in the assessment of the intervention. So we are asking caregivers about their perceptions of how their dependent engaged in the intervention, how they might have benefited from it, what some barriers or obstacles were. So we'll be gathering some of those data at the end of our evaluation.
Thank you. Another question. Will the focus of telecoaching change given the impact of the highly effective modulator therapies?
Oh, another great question. And again, in a quick presentation, it's hard to talk, but that last slide had a lot in it. So we have experienced quite a bit of twists and turns in response to the release of Trikafta, for example, but also the pandemic. And as others have mentioned, we struggle with recruitment, and certainly telehealth offers a great number of advantages for dissemination, but yet I think in this pandemic era, we're kind of experiencing the Zoom fatigue and things like that. So again, I think we've had to really twist and bend, and certainly we are looking at the CFTR modulators. It is a treatment component that can be targeted specifically in this intervention, but we are keeping a sense of what's going on with that. We're using some questions at the end of the intervention to get a sense of whether adherence and adherence concerns are shifting as a response to that, and how that might be impacting our feasibility as well in terms of recruiting people into the intervention.
Thank you. Another question. Do you have a breakdown of the specific disciplines of the coaches or who are or will be trained to provide the interventions? And kind of a follow-up question, do you think that eventually some of these materials will be disseminated more widely, some of your coaching materials?
Yeah, absolutely. The intervention is designed to be delivered by a range of disciplines within the CF care team. So we've had nurses, social workers, psychologists, respiratory therapists, dietitians. So really it is designed, it's not a mental health treatment. We really focus in on that when training, but also when introducing it to the participants. This is not a mental health treatment. This is a coaching in terms of daily cares. So we've really done a lot to provide great detail in our training. Our manual is very, very detailed, and the training sessions are as complete as they possibly could be. Again, a lot of attention has gone into that. And then we have the ongoing supervision. So overall, we feel that we were able to open it up to a wider range of care team members by providing all that infrastructure and support in place. And as for the materials, we're going to make sure that we have a good intervention and that we've tested it before we'll release those materials. But our ultimate goal is certainly to disseminate this intervention if it's deemed to be efficacious, but we certainly don't want to be premature with that. So we're going to continue to work on honing and testing it, and we'll certainly release it as soon as we possibly can.
Very much, Dr. Duncan. I think that, this is a really promising intervention, and a lot of the questions from our audience have been, how can we get these materials? How can we get these interventions for our patients? But I think your point of making sure it works first is really an important one. And I appreciate that all of our speakers today measured their outcomes and are measuring their outcomes and looking to see what really does work. So. And I believe that Shana will be putting up the email addresses for all of our speakers into the chat box, so that if people have additional questions or are interested in getting some of the materials, they can send a message directly to our speakers. So thank you, Dr. Duncan.
Thank you very much. Appreciate the time.
Yeah. So I think that brings us to the closing of our novel virtual psychosocial interventions workshop. On behalf of Shana Blair and myself, we really appreciate your time and attention and hope that you have a wonderful rest of the conference. And I really hope that we can all get together again in person soon. Thank you very much.